So I was asked a few days ago if I could come do this, and I was happy to. And I thought, because I love infectious diseases, and I know a lot of the talks here have been more the future of medicine that not necessarily has everything to do with clinical, and I thought that this is a great topic that I was asked to do here. So Ebola virus, 2014, and what I basically write there is the truth. Is that not since around 13 years ago, 2 weeks ago, October 2nd, 2001, when anthrax came around, have I had so many questions about a disease, one particular disease. And the first question is, are you concerned? Well, how could you not be concerned? Are you afraid? Honestly, I got asked that 20 minutes ago before we got here, and no, I'm not afraid about this kind of thing. I don't think about it that much. And the last thing is, what can we really do about it? And the truth is, it's the folks in the room here who have to take control, otherwise it will be out of control. It's really not much different than, as I see it, from the political point of what was going on with anthrax in 2001. And if you've ever been to one of my anthrax talks, the amazing part to me was the science and the whole idea of bioterrorism and anthrax. But the bigger part that I learned from was the politics behind the scenes, so that when I read in the newspaper and hear on the radio and watch the TV newscasts about Ebola, I'm fairly suspect about what's being said. I can tell you, at the first meeting of anthrax in the boardroom at JFK at around 2 o'clock, October 4 of 2001, and we had the CDC, the federal government, the local government, the state government, and I'm sitting there, and we're on a speakerphone with the White House. And the first thing out of their mind was, here's what we're going to say. I thought, why not just say what actually we know? I mean, that seems like a good place to start. Let's say what we know. And then we have Tommy Thompson get up on the TV screen, which we had on the screen there, and the Secretary of Human Health and Services. And he basically said, we have a man in South Florida who went fishing in North Carolina, and he has anthrax, but we don't think it has anything to do with anything. And I looked at the CDC people sitting across from me, and I was saying, that's fascinating. That's your statement. I turned to the man next to me, whose name was John, I'll leave out his last name, who was an FBI agent from Miami, and I said to him, who are you? He said, I'm an FBI agent. I said, what do you do? He said, I do bioterrorism. I said, but he just went fishing. So before we actually went to the Kennedy conference room and had a disclosure about what was going on, and it was a huge press conference, I warned the CDC and the State Department that, listen, I know what you're going to say, but that's not what I'm going to say. So before I embarrass you, what I'm going to say is, we have anthrax in the United States for the first time ever, inhalation, the first time in Florida ever. There's been 18 cases in the United States in 100 years. All of them were occupationally exposed, and this guy has no reason to have this. This is bioterrorism until proven otherwise. When you look at this and you see some of the things that are coming out from the government, it makes me think of the same thing. But let's keep in mind, Ebola isn't just the only thing we've ever dealt with. And everything that we've dealt with before, which may be good or bad or just as bad or still ongoing. For instance, the 1918 Spanish influenza epidemic, the greatest epidemic in the history of the world. I don't know if you're aware of why it's called the Spanish flu. It's called the Spanish flu because the Spaniards were the first one to recognize, hey, there's something going on here that's unusual, that's bad. I'm a little privy, or I'm a little, have a little bent for Spaniards because I live with the greatest pathologist I've ever met, the best physician I've ever met, who actually the reason we just ran in here late, because Dr. Maria Perez, which is now Dr. Maria Vasquez Pertejo, just became a United States citizen today, right down the street. So we have the Spanish flu, of course. We had smallpox that theoretically is eradicated since 1979. Who can say we have anything about HIV and AIDS, the greatest social, economic, medical thing that's ever happened in the history of people? Tuberculosis is the #1 reason why people with AIDS in the world die. Malaria is the #1 infectious disease in the world. And then we have the dengue hemorrhagic fevers, which is the most common viral-borne disease by a mosquito in the world. And we don't give a lot of thought about that. I've heard on the news it's more likely that somebody with malaria is going to walk in the door. Look at what happened in Spain in the Spanish influenza. It was the greatest epidemic. Look at the bottom graph there. The life expectancy in 1918 dropped 20 years. There were 50 to 100 million people who died from the Spanish flu. And having said that, it doesn't look much different than what's going on in West Africa with Ebola. That's basically what's going on in West Africa with Ebola right now. And even having said that, everything we know about preventing influenza influenza and secondary pneumonia, the number 6 cause of death in the world. Imagine that, the number 6 cause of death in the world. Our goals of vaccinating people over 65, and if you go to the far end of the slide, of vaccinating healthcare personnel, is dismal. So everybody's worried, where's the Ebola vaccine? And I say, hey, you got the influenza vaccine, and nobody seems to want to take it when it's the greatest epidemic that ever happened in the history. And then we have other emerging infectious diseases, and the reason why I always love infectious disease, because it's emerging, it's living, it's an ongoing process. I always tease my, cardiology, colleagues, what's there, a new stent? There's no new anatomy, there's no new disease, there's a new toy, there's a new stent. But look at this, it's amazing. We have H5N1 bird flu, and then we had SARS in 2003, and then Middle Eastern respiratory syndrome, followed by chikungunya virus, and enterovirus. We had the first enterovirus D68D case in Polk County, Florida, October 7th, the first one in a 10-year-old girl. And then, of course, we have the Ebola virus, which isn't new, but it's new because it's the greatest epidemic of Ebola virus that we've ever had. So if you look at what Ebola virus is, it's in the group called Filoviridae, which is made up of 2 species, Marburg and Ebola. Marburg virus was actually seen before Ebola virus, and it was found in Germany, in Marburg, Germany, where lab workers working with green monkeys developed it. There were around 37 cases in a large outbreak, and there's been a few outbreaks since that time, mostly in Western Africa. But that really hasn't gotten the attention that Ebola virus has, which was first really found in 1976. It's named after the Ebola River in Western Africa. The first cases were in northern Zaire, which is now the Democratic Republic of the Congo, in the Sudan. And there are actually 5 species, and the worst species that causes the most mortality is the one that's gone on now. It's called the Zaire species. The last one, the restin species, we don't even know if that occurs in humans. So it's a zoonotic infection. It's spread by bats, as a lot of diseases are. And here's a little bit more information. As you know, a lot of people have written books about this because it gets people's attention and it makes good movies. There are 5 species, as I said. The fatality rate with the Zaire virus, which is the one that we're seeing now, is quite high. It's transmitted by fruit bats. The first outbreak, as I mentioned, was in 1976, and most of it's always been located in Central Africa until 2014, when all of a sudden it started moving west. And it moved west to Guinea and Sierra Leone and Liberia. And having said that, if you look at the 33 outbreaks that have been documented since 1976 to 2012, I only put the largest ones there. You can see why all the attention's being given now, because the caseload was somewhere between 300, 400, 100, and the mortality rate, as you can see on the right-hand side, is great. The one that was 25% was one of the species of Ebola virus that didn't quite seem to be, as virulent. But the outbreaks have been ongoing and ongoing until we get to the 2014 outbreak, which really started in Sierra Leone and Liberia and Guinea. It started in Guinea. But what's different about this outbreak is it's the furthest west in Africa that Ebola outbreaks have ever really occurred. And now we know that there are 3 types of spread. There's the widespread transmission, and this data is as of yesterday morning. And already this morning, when I clicked on the computer, that 8,011 cases was up to 8,033 cases, of which you can see has a fatality rate of around 50%. The travel-associated cases, well, everybody's familiar with the United States case. Unfortunately, the man who came from Liberia walks into an ER, and the medical opportunity to make the first diagnosis to stop what's happening in the United States is sent home. And that's a concern. And that's a concern. And I think the CDC hasn't really come out and said that was a faux pas. If you look at the travel-associated cases, there's 1 in the United States. I see Abby Strauss is in the room, and around 6 weeks ago, or maybe longer, we did a podcast for the Palm Beach County Medical Society on infections, and we mentioned something about Ebola. And Abby asked me, do you think we're going to see Ebola in the United States? I said, well, we have seen Ebola in the United States. We brought it over by airplane. We put it in Emory University Hospital. Whether anybody thought that's right or wrong, I personally think it was right. But yes, Ebola is now in the United States. In fact, it's been brought here 5 times. In Atlanta, Nebraska, etc. 5 people have been here. But now we had the first case of travel associated that wasn't brought in. He also asked me, do you think you will see Ebola naturally? And I said, absolutely. How can you avoid it in a global world? with travel. And then we have the localized transmission cases, and what you're hearing about now is the nurse in Spain who was taking care of the priest who was flown to Madrid, and she took care of him and claims that she was wearing all the protective equipment, whether that's true or not, and she has it. So there are three classes of disease now: widespread, travel associated, and localized transmission. Well, a little bit of what the CDC puts out is that they tell you about the countries where it's been. Somebody traveled to Nigeria, of which there are about 20 cases now. They tell you that 1 in 2 people who get it will likely die. I guess it depends where you get it, because the healthcare system changes. But what's most important is the fear factor of how do you get this. It's almost like what I tell people with HIV. It's 100% preventable. 100% preventable. You don't seem to care about influenza, which isn't. But you care about HIV, which you can prevent totally. Well, it's the same thing with Ebola. It's transmitted only by close contact with secretions. And they're listed there. Contaminated objects can also give you Ebola virus. So anything that the people have touched obviously is a concern. But I find the last thing fascinating, the infected animals. I don't know if you know this, but the people that got quarantined, who the nurse in Spain was exposed to, they also had her dog. So her dog was in her house that she was going home to. They euthanized the dog the other day, which a lot of veterinary people in Spain were against, and I'm against too, because I don't think we really know that it's transmitted from animals. The problem is, animals don't get sick. So if you quarantine the animal, you can't really tell if they're getting sick. It won't work. You have to keep testing the animal. And if you test the animal, and they do have evidence of Ebola, are they really going to transmit it to humans? So that's a concern in the veterinary population. The early symptoms, it looks like the flu, and then eventually you get very sick to the point where you may need dialysis or a respirator, and you go into shock and you bleed, and you get pictures like this. Most of this is looking at the coagulopathies on the bottom. The incubation period is 2 to 21 days, and what we keep hearing on the news that's supposed to make you feel good, and it should in a sense, is that you're not contagious until you're ill, and if you're that ill, you're not going to travel. Well, no disease works in the perfect shape of a bell. There's always outliers. There are obviously going to be some people who are not so ill, but they're contagious, and they can travel. So this 2 to 21 day thing that we keep hearing about is really true, but it's not 100% true. And as long as that's the case, there's risk. So let's talk about when is somebody able to spread it. Well, here's the CDC slide between day 2 and 21. That's a little ridiculous in my mind. Of course it's not that way. There are people on day 1 and people on day 38 who are not necessarily ill, who can still potentially transmit the disease. And this is the biggest problem on this CDC slide, is this right here. Ebola poses no significant risk to the United States. I don't know how the director of the CDC let that. I know Julie Gerberding would not have put that on her, who was his predecessor, because that's obviously incorrect. So how do you diagnose it? Well, you got to think about it. I got asked that question 1 million times. How'd you diagnose anthrax? And I say, well, how would I not have? I thought about it. I mean, it was right there in front of my face. It was just thinking about it. So if somebody walks in the ER, or somebody gets off an airplane and says, I feel sick, whatever that is, whatever that means, and they tell you they've come from Western Africa, you have to isolate them. And then we do various tests, and the tests that you can do are based on PCR mostly, but also antibodies. And this is, I know you can't read this, but this is the sheet that the Florida Health Department distributed this week, basically saying that if you have a suspected case, the algorithm to go through, and you can pull this up online and read it. And this is really, really, really for primary care doctors and for urgent care centers and for emergency rooms. Because by the time they reach other specialists, they should have been diagnosed, or it should have been thought about. If you look at the treatment is there is no treatment. There are no FDA-approved drugs. There is no vaccine. It's a so-called supportive care and isolation. But there are a few experimental things that have hit the news. In fact, it's become more political than medical. The biggest one being, how come the man in Dallas didn't get any of these monoclonal antibodies or 2 drugs? This is a drug that looks like cidofovir. Cidofovir is sort of a third-line drug we use for CMV. But it also has activity against smallpox. That's good. And Ebola virus. This is fascinating. There's one of our medical residents who graduated last year. He's now in critical care at the University of Miami, and we keep in touch via the email. And I thought he was a very good resident, and he loves medicine, but what he really loves is investment. And he loves biotech investment. He must email me every day about this stock. This is a Canadian company that has a drug for Ebola. And actually, when the outbreak first started happening in March of 2014, he was on me every day and saying, what do you think of this stock? What do you think of this stock? I said, well, the truth is, unless that virus leaves Africa, it's useless, because nobody's going to buy the drug in Africa. Well, it left Africa. Right? It's the United States and it's in Spain. So he is very hot on this company. I don't know if this is ever going to come to fruition. The bottom line is that what JFK said, one of my favorites, there's the risks of cost of action, but they're far less expensive than long-range inaction. And I think that's what's been going on. We have to take control. We can control this outbreak in the world. We have to go to West Africa and do what they can't do. And it's not about giving any medication. It's about rounding up the people and doing what happened with SARS, what happened with smallpox, and what happened with MERS, is catching the people who are sick and doing the right infection control. The greatest things that's ever happened in the history of infection were hand washing, sanitation, and vaccines. Not antivirals, not antibiotics. Thank you for listening.